Hi, welcome to the talk on multiparametric imaging of bone marrow in cancer. These are my usual disclosures. As usual, let's just start off with a case study. So here's a 34-year-old female, a BRCA2 carrier, who's had a mastectomy for a lobular carcinoma. She seems to have received all the treatments that she should have, but she represents with sternal and right chest wall pain. As per protocol, she has a bone scan which shows 3 lesions: the sternal bone, the right lower rib, and posteriorly in the right iliac bone. But what I'd like you to do for the purposes of this talk is to look here anteriorly in the left iliac bone, and you can see there's a symmetric appearance. However, on the CT scan we can see a lytic lesion. Here it is confirmed on the high B value image, not so well seen on the T1 weighted gradient echo image. So how do you explain the fact that this metastasis anteriorly in the left is not depicted on the bone scan, but is seen on the diffusion weighted sequence, and how common is this? Well, it turns out that if you look at a bunch of metastases and you classify them by the cellularity, you can have different patterns of cellularity and sclerosis. So you can have a low cellularity metastasis, which is osteoblastic, like this lesion here, or you can have lots of lytic lesions, but still be of low cellularity. And many of you will ask me why and when this happens. Well, this is classically the appearance that you would see in multiple myeloma, this particular pattern. And if you were to do bone scans and CT scans and MRI scans, what you would find is that in this particular instance, the CT scan and the morphological MRI scans would be abnormal, but the bone scan and the DWI would be negative. In this particular pattern, which is the multiple myeloma pattern, you can see only the CT scan is normal and the other techniques are not abnormal. Similarly, you can have high cellularity, and you can have a range of appearances from a ground glass woven bone type appearance to a osteolytic pattern with and even a normal pattern. But the most common pattern one sees is the osteolytic, osteosclerotic pattern, which is often seen in breast and prostate cancer. And again, you can see that depending on the sclerosis, the CT scan and the bone scan may not be positive. So here, for example, and I'll show you this particular patient in a second, you'll see multiple osteolytic lesions, negative on the bone scan, but obviously positive on the CT scans, and because of the higher cellularity, was visible on the morphological MRI and on the diffusion imaging also. So why do you see different patterns on the different imaging techniques? Well, the first thing you need to understand is that the biology being depicted by imaging techniques varies according to the technology used. So, for example, if you wanted to look at the cellular content within the marrow space, the fat content, then you're probably doing quite well using diffusion sequences or fat and water imaging using the Dixon technique. If you are interested in the bone itself or bone erosion, then CT scans really work very well indeed, but there are other techniques. If you are interested in the osteoblastic activity of these lining cells, then a bone scan or a sodium fluoride PET CT scan seems to work quite well. However, if you're interested in the malignant cells themselves, then you may want to look at other parameters, other imaging technologies, which may be either tumor cell surface or cytoplasmic specific, such as FDHT PET scans, FES PET scans, gallium PSMA, or you may want to look at a non-specific metabolic marker such as FDG PET or choline PET or methionine PET. And the important thing to remember is that by using different techniques, you end up with different descriptors of any given patient. So here are two patients with breast cancer. You can see that the patient on the left-hand side is a 35-year-old female, again with a lobular carcinoma. You can see extensive sclerosis on the CT scan, a negative FDG PET scan, but a positive diffusion scan, whereas in this 65-year-old with breast cancer you can see mixed osteolytic lesions on the CT scan and positivity both within the marrow space on the FDG PET scan as well as on the high B value images. So what are the interactions between tumor, the marrow cells and the bone stromal cells that lead to osteosclerosis and osteolysis? Well, here's the normal, schematically shown the regulation of the bone, and we know that osteoblastic recruitment and activity causes osteosclerosis, osteoclastic recruitment and activity leads to osteolysis. In many metastases you have a spectrum between osteosclerosis and osteolysis, and if you have more OPG then you tend to go towards osteosclerosis. If you have more rank ligand then you tend to go more towards osteolysis. I just wanted to put a little bit more flesh on that with this diagram, which essentially shows the same thing but in a little bit more detail. So if you have tumor cells sitting in the marrow space, you can see this is a osteosclerotic lesion. We can see multiple crystals, we can see tumor cells in the periphery of this lesion. Osteoblastic recruitment leads to osteoblastic differentiation. Osteoblastic lesions are formed with osteosclerosis, but at the same time you will notice that within this sclerotic bone disease there are in fact areas of osteolysis, and these areas of osteolysis are partially mediated along this route here, which is an alteration of the OPG rank ligand ratio, which when activated leads to osteoclastic activation and the formation of osteolytic lesions. Now, osteoclastic activity can be directly stimulated also by the tumor cells, and there are four different mechanisms. One's a direct stimulation of osteoclasts, another one is inhibition of osteoblastic function, and the third mechanism is to interfere in the interactions that occur between osteoblasts and osteoclasts. So regardless, if you activate if you activate osteoclasts, that leads to osteolytic lesions, which then release growth factors from the bone itself, which then perpetuates tumor growth. So if you look at this particular patient, and this is the same patient 1 year apart, slightly different slices, you can see that this patient previously in June 2014 has a mostly osteosclerotic pattern, but a year later you can see that in fact there are large areas of osteolysis beginning to develop. And it is these interactions between the tumor, the marrow cells, and the bone mesenchymal cells that result in these distinct imaging phenotypes that we have previously described, but which I have outlined here in a little more detail. So there are a number of different patterns that one can see on CT scans and bone scans and MRI scans, and the common types of tumors that cause this type of these types of imaging phenotypes are shown on the left. Now, we don't have time to look at all of these phenotypes today, but what I'd like to do is to concentrate initially and discuss with you a little more what I call pattern 2. Pattern 2 refers to osteolytic lesions with highly cellular marrow, and this is commonly seen in multiple myeloma, breast cancer, and in lung cancer. And I just wanted to show you an example of what this looks like. So here is a patient who has predominantly osteolytic lesions. You can see that on the CT scans, sagittal and axial images. The bone scan is normal, but look at the diffusion scan. If you look at the diffusion scan, you can see extensive marrow infiltration throughout the spine and in the bony pelvis. And this is a typical pattern where you have mostly osteolysis, but very little in the way of osteosclerosis, so the bone scan is negative. So essentially we have this pathway is activated, leading to osteolysis. Another pattern that I'd like to talk to you about today is what I call pattern 5. Pattern 5 is not uncommon, and especially in breast and prostate cancer, and these are osteoblastic lesions that are often bone scan positive. Another pattern that I'd like to talk about is what I call pattern 5. This is the most common pattern one sees in breast and prostate cancer. It's very classical, and it consists of osteoblastic lesions which are highly cellular. Bone scan is positive, but in the center you have calcification, and in the periphery you have what's called the halo sign. So what does this look like? Well, here's a patient with metastatic breast cancer. You can see some really quite interesting features on the sagittal STIR, T1 and CT scan, all done on the same day. Now, there's a couple of features that I'd like you to concentrate on. Firstly, I'd like you to look at this lesion here. Anteriorly, you can see it's very well seen on the T1 sequence, less well seen on the STIR sequence, but you can see that it is in fact osteoblastic because of the CT scan. And if you look around the edge of this lesion, we can see there's a very faint halo. That halo effect is, I think, shown much better at the bottom here, where we can see this lesion has quite a thick halo, but very even. That corresponds to this metastasis, which of course you should now recognize as an area of sclerosis. I think that one of the most fascinating metastases in this particular patient is this lesion here on the T1 sequence. You can see it extends anteriorly to posteriorly. Clearly there's an alteration of signal more anteriorly, which corresponds to this area of calcification on the CT scan. But the metastasis is much bigger on the STIR sequence. It goes all the way from the front to all the way back, and that posterior extent is really not well seen. Now, axial images through 2 lesions are shown here. So you can see that there are 3 metastases in this particular vertebral body, but if you just concentrate on this anterior and posterior lesion, you can see the anterior lesion, which is the more calcified lesion, is in fact less hyperintense than this posterior lesion. The posterior lesion has a small area of nidus in the back, or mineralization, and here is that mineralization with this halo around it on the CT scan. So why does that happen? Well, that happens because of osteoblastic recruitment. So osteoblastic recruitment results in osteoblastic differentiation and function. That leads to osteosclerosis in some of these deposits. However, as I've already said, there is an activation of the OPG rank ligand ratio, which is responsible for the halo that you can see in the back of the lesion in the spine. That halo is very, very classical. And here is a patient, another patient with breast cancer, and we can see this halo develop as a lesion grows over time. So this is the same lesion. At the posteriorly you see a new lesion growing, and that lesion is in fact, that halo in fact is what we need to concentrate on. That's the area of osteolysis. That's the area where you have the highest cellular packing. And in fact, if you look on the axial images on the stir sequence, if you just concentrate on that lesion there, which you can see is a small ring-like area that gets much bigger, that area classically has a higher signal intensity around the edges, indicating an area of therapy resistance. And if you look at this sclerotic metastasis in the left side of the sacrum, again we see this ring. So that's the area of osteoclastic activity. That's the area where there is higher cellularity. And in the center of the lesion, that's where you have the small amount of central mineralization. And this has been shown classically in this very nice study which was published last year, with the metastasis growing on the skull of a rat. And if we just look at that inferior margin of the lesion, and there is the high cellularity along the edge of the lesion with woven bone on the inside and cortical bone on the outside. Okay, so now let's discuss the value of multiparametric MRI for looking at changes of the malignant bone marrow with therapy. And what I'd like you to do is assess this case for me. This is a 41-year-old female with breast cancer who's being treated with chemotherapy. And what I'd like you to do is to look at these images and tell me if you think the patient's responding, whether she's got stable disease or whether she's got progression. So here are the images again. You can see on the T1 sequence there's darkening of the normal bone marrow. We see loss of vertebral height. Here is the T2 sequence before and after treatment. Again, you see this loss of vertebral height. The bone marrow is slightly brighter on the post-treatment scans. So what's your assessment? Response, stable, or progression? Now, traditionally, using morphological sequences, you might have said, well, loss of vertebral height, new bone marrow abnormality, therefore this is progression. But it turns out that on diffusion sequences, this is a response to treatment. So here are the high B value images before and after the treatment, and you can see that there has been a complete shift of the histogram to the right, and here is the 1500 line, and you can see the majority of the pixels post-treatment are above the 1500 line. And this shift of the histogram to the right represents cellular kill, which results in more fluid in the extracellular space and that is directly responsible for the shift of the histogram. Now, if you follow this patient over time, you'll see that there is a new liver metastasis that appears, which we ablated, and then there was another lesion that appeared a few months later, and that was ablated. And then in July, almost a year later, she seems to now to be progressing within the bones, so she's got reactivation of bone disease. So the question that I want you to answer is, what causes of this fading of the bone marrow over time? Now, if you look at the T1 rated images, you can see that the cause for the fading of the bone marrow over time is in fact due to fatty repopulation of the marrow. We also see this new vertebral fracture, but again it's got normal marrow within it. But there are also bone marrow scars that are visible, and it's not possible to state categorically on the morphological sequences whether this is due to reactivation of disease or whether these are just scars. But I think the diffusion images, were quite convincing that these in fact represent scars. What happens then to the ADC histograms? Let me just show you what happens to the ADC histogram, and I think this might be the better image to look at. Here is the signal intensity. You can see over time the signal intensity decreases. The ADC goes up, as we've already noted, with most of the pixels above that 1500 line. But look what happens over time. As the patient improves and you get repopulation of the normal marrow with fat, you see a decrease in ADC. So this decrease in ADC is accompanied by a decrease in the signal intensity, and in fact this is repopulation by bone marrow fat. And if you look at the T1 relative fat fraction image, you can see that before treatment there's hardly any fat. Then as the patient recovers, you can see repopulation of fat. So in fact the changes that you see on the ADC values are a combination of early cell kill and late repopulation by normal bone marrow. Now, the chemotherapy pattern is very different to the pattern that you see with a different mechanism of cell kill, such as apoptotic cell death. And what you have to remember is that necrotic cell death is a kind of homicidal killing of cells. There are marked increases in ADC values because there is inflammation and edema that is secondary to cell and nuclear lysis. Apoptotic cell death is a sort of suicidal cell death. This is not accompanied by inflammation. There are apoptotic bodies that are formed, which are then swallowed by neighboring cells, and the ADC change depends on the balance between apoptosis and repopulation. And in fact, you just see modest increases in ADC values. I just wanted to show you an example of that. So here's a patient. Here are the T1 and here are the T2 sequences. And it's very difficult to say whether there has been a dramatic response between examination number 1 and number 2. Certainly by number 3, you can appreciate that the fat is beginning to repopulate. I think if you look at the high B-value images, I think it's a little bit more obvious. So here we are. We can see between here and here there is some fading of the background bone marrow signal. You can make out that certainly after 3 cycles that the bone marrow signal is beginning to decrease. And in fact, it's very interesting to look at the histograms of this particular patient as well. And you can see that here are the ADC values. You can see that the ADC value goes up, but not it doesn't go over that 1500 line. So here is the prior histogram. The blue here corresponds to the blue here, the orange corresponds to the orange here, and this is that 1500 line. So you see a slight shift to the right side, and on the third examination you can see that in fact the histogram starts to come back, and again it's got that flat appearance that we were looking at previously. And again, this is very typical of what you would see in the apoptotic cell kill. Now, I just want to show you one last example because I think it's quite illustrative. So here's a patient with advanced prostate cancer. He's got castrate-resistant disease, he's failed docetaxel, he's failed abiraterone, he's got large volume bone disease, and he's been treated with radium-223. Now, if you look at his examinations, you can see that in fact on the T1 sequence he looks worse. So here we go. Fat was present in the dorsal spine. You can see this diffuse increase in signal. The patient was irradiated in the lumbosacral spine. This is a classic spade radiotherapy fingerprint, and even here you see increases in the signal intensity on the T1 sequence. Sorry, decreases in signal intensity on the T1 sequence. But if you were to then look at the high B value signal intensity, you can see that the patient has progressed. So for example, here in the lumbar spine there was no signal intensity, and in fact you can see here that the patient is developing increasing signal in the lumbar spine. He has new lymph nodes in the retroperitoneum, again in keeping with progression. But the interesting thing is this, that the PSA value has actually dropped. So how does one then explain the fact that the PSA has dropped and everything else looks worse? Well, if you then look at the histograms, again you can see this phenomenon of a shift of the histogram to the right side, and it's interesting to see that the histogram is rather flat. This is the 1500 line. So clearly there are cells that are dying. The question is, where are these cells actually present? Now, if you were to look, what I'd like you to do now is just to focus a bit more in the dorsal spine and in the lumbar spine. If you look at the T2 sequence, you'll notice that the T2 sequence in the dorsal spine has increased, suggesting increased tissue water. If you look at the signal intensity in the lumbar spine, it has increased, but it's nowhere nearly as bright as the dorsal spine. So there is a difference in the signal intensity between the lumbar spine and the dorsal spine. And on an ADC map, it's quite clear what's happening. So here is the low signal intensity before treatment. Look what happens here. There is a dramatic increase in the signal intensity in the dorsal spine, whereas in the lumbar spine, this is the lumbar spine before treatment, this is after treatment, and look, the ADC values are low. Whereas if you were to look here at the hips and proximal femora, you can see that in fact there's also been a good amount of cell kill. So in fact this represents a differential response. So this increase in water in the dorsal spine is in fact response. This is pseudo-progression on the T1 sequence. However, in the lumbar spine, this minor increase in signal intensity in fact represents true progression. So a very interesting illustration of the pseudo-progression phenomenon, and also of the ability of MRI to demonstrate heterogeneity. Now, why do we want to have such levels of sophistication? Well, the interesting thing that MRI, and particularly multiparametric MRI, lets you do is it helps you to change the current paradigm of assessment of bone disease. Currently, bone disease are assigned two classifications: no progression or progression, and new ways of doing this, including multiparametric MRI, allows you to look at bone disease and say this patient is responding, this patient is stable, this patient is progressing, or even or is developing a heterogeneous response to treatment. What are the professional challenges of multifunctional imaging like this in therapy monitoring? Well, one of our biggest challenges is that we are doing multiple tests. So in the bone marrow, it's fat fraction, it's ADC maps, it's CT Hansfield units, it's activity on a PET scan, it's all kinds of stuff. And when we acquire these sources of data, then integrating them is a real bioinformatics challenge. We also need to deal with heterogeneity, and I just showed you one example of heterogeneity. Heterogeneity occurs between lesions within the same patient, and that's what I've just shown you, but clearly heterogeneity exists between patients and even within lesions, both at baseline and in response to therapy. We also need to develop a better understanding of the biology behind the image, and that is an area that certainly needs development. We need to develop common standards, measurements, and analysis tools for whole body bone imaging. And in this regard, there are new developments that are occurring, and these new developments include the new METRADS-P reporting system for whole body MRI scan, which has been submitted to European Urology and will be available online soon. So I'm going to stop there, if I may, and I'd be happy to take any questions.